but we don't have
Yes, sir. The class.
yes.
10 o'clock.
Good morning, everybody. Good afternoon.
Good
Emmanuel.
morning, good afternoon, Dr. Barra.
Yeah, nice to see all of you.
You are most welcome.
I hope you can see me okay. I have my head up.
Mhm.
And did you get my PowerPoint, please?
Yes, we do. Yes, we do.
So somebody can just project it for me as I speak along when
Absolutely. Absolutely. We're going to do that for a few other doctors here. So,
It's so nice for you guys to organize. It's very important.
you're welcome, sir. Mr. Class, it's your turn now.
Okay, so we start. Okay, my name is Winston Class, and I'm the moderator for this ePanel discussion. I'm from the Walnut Foundation, and we've been 15 years in the business of addressing concerns with regard to Black men and prostate cancer. And hopefully my experience with the Walnut Foundation and all that will help in this regard. First, I'll talk a little bit about the Walnut Foundation and what it's all about. There's some slides addressing that. If you could just forward up the slides so I can talk to it. And the next slide, yes. We are a nonprofit charity, 100% volunteers. We have trained members, trained at the Princess Margaret Cancer Center. And these members are trained to mentor people who are prostate cancer patients. Our funding comes from an annual walkathon and from grants that we get from the government. Next slide. Our purpose is just to bring awareness to the community through education, monthly webinars, conferences, community presentations about prostate cancer. And we're moving on to men's health. We transition into a broader type of agenda now. We also have a Black men support group. We think there are some unique needs that Black men have. And It's a monthly session. It's a Zoom session, and it's on the last Thursday of every month at 7 o'clock. It's been on for over a year and doing very well. And if should you know of anybody who is diagnosed with prostate cancer who could benefit, you just could get them to go to our website, and the link will be there for the next meeting. We take part in more and more in health research targeted to the Black community, and there are a lot of biases in the health system, and they're well documented, and we educate men, particularly at the support group meetings, to be aware of these biases and to be able to overcome them and such that they can get the best treatment possible. We do also health research regard to genetics and Black men, and the fact that the immigrant population and the older population could be better educated as to how to use the health system. So that's very much a part of our partners in research. We also fund scholarships for Black students in medical programs. We realize that the more you can get Black persons as health professionals, the more it serves to eliminate the biases that are in the health system. For information, there's our number, and there's our website at the bottom there. And anytime you want to contact us, the information is right there. Next slide. This might be a fairly busy slide, but all it's saying is that on the left-hand side, you see that long bar on the left. Forget about the numbers. It's associated with a 4 to 6. For all races, it's a 21, and for Black men and in the Caribbean and West African, it's 4 to 6. That's an index that measures the extent to which there's incidence of prostate cancer in the group. So you can see that there is a special connection between us and prostate cancer. It's 76% more likely to occur among Black men. And once we get it, we're twice as likely to die, and we'll get more into that. Okay, thanks. Next slide. Now, before I go into the next slide, I just want to say that very briefly that I was diagnosed in 1996, and I opted for surgery. And I've forgotten really that I was diagnosed with prostate cancer, because my PSA has been under control, and the reason why it has been under control is that I caught it early. And that's going to be the message. If you catch it early, if you're destined to be that prostate cancer gets into your life, if you catch it early, there's almost 100% chance that you'll die from something else. It's when you catch it late, that's the problem. I'll pass it over now to Bill Oladelli, and he's going to talk about his foundation.
So good morning, everyone. My name is Bayo Oladele, as you will see in the slide. And I'm speaking for the African Cancer Support Group. Just so we know, this program is organized by two foundations collaboratively. The Walnut Foundation is based in Toronto, Ontario, while the African Cancer Support Group is based in Calgary, Alberta. So it's East and West combined together to set this thing up. We cover the whole country. Next slide. Okay, myself. So just what I said. So African Cancer Support Group is a member of the Oladele Foundation, which is a charitable nonprofit organization. And now about myself. Again, my name is Bayo Oladele. I am a cancer survivor. I'm the president of the Oladele Foundation and the African Cancer Support Group. The group was founded in 2018, after my journey with multiple myeloma cancer in 2016. Okay, what we do or why ACSG? ACSG is established to help survivors, patients cope with emotional trauma caused by the cancer disease. We all know that the aim is to support survivors, patients, caregivers, and to share stories, symptoms, information, and coping strategies. To create a safe place where to share information, coping skill, and most importantly, a place to give and get emotional support. And why she joined? Well, being a support group encourages healing and can help everyone develop new skills to relate to others. And one other thing is that ACSG cares and caters for all cancer patients. And that was not indicated in here anyway, but we care for all cancer patients. Yeah. So, this is not what I changed. How we serve people of African descent and anyone that reach out to us. Like I said before, we serve all cancer patients. It doesn't, we are not focused on one particular cancer. We meet bi-monthly, we provide bi-monthly education and awareness program with formal presentations. We have bi-monthly member meetings to share and encourage one another and each other. We also have annual cancer survivor celebration. That one is where we bring the whole community together to see, just to educate them about cancer. We are a corporate community and church presentations. We also have peer-to-peer support. We're collaborating with other organizations, just like we are doing today with Walnut Foundation. And of course, our funding actually comes from grants and donations. Next slide, please. We are a charitable, like we said before, a charitable nonprofit organization. And of course, your donation empowers us to create future programs that benefit members of our communities. Slide. In the Black community, so we are here for you, and that's in the Black community, the stigma and taboo surrounding cancer prevent people from speaking up and seeking help. That is very clear. So because of those stigmas and taboos, the Walnut Foundation and the African Cancer Support Group today are here to help you navigate your cancer journey. We provide so we offer education and awareness, complementary therapies, mental health support.
1 minute.
Okay. Then continue, you join us on the slide.
Yes.
Yeah, we offer education and awareness as community cancer education and awareness program, complementary therapies, mental health support, emotional support, health and wellness support, and material support. And in our material support, we provide meal and care package. We clean the house or of our patients and members. We also offer minimal financial support when possible. All these, like we said before, are funded by grants and donations from community members and organizations. So today, this is just our disclaimer that African Cancer Support Group and the Walnut Foundation do not provide medical advice. Experiences raised by the survivors and panelists are those of the lived experiences of our members. They are not recommended medical solutions. For medical treatments, please consult your doctors, medical teams about your specific situations before embarking on any health program. Next slide, please. And of course, all right. So how to donate? Because like we said, we are funded by grants, by donations from members and people like you. You can donate to the Oladele Foundation, that is the African Cancer Support Group, through e-transfer. You can go to our website at africancancer.ca. You can make check to African Cancer Support Group, and of course, to the Walnut Foundation. The website is there to donate. The transfer could be sent to info@walnutfoundation.com or check to Walnut Foundation. And I think that's
Okay, should I continue? Okay.
That's the end of my own part. Mr. Klaus, please.
Okay. I'm just going to take you through a bit how we're going to proceed from here. It's going to be a little bit different because we're trying to move to a fairly tight schedule. The bios, we have 4 presenters, and the bios are going to be read out at the start. And after this, then the speakers are going to present in turn. Okay? But we encourage no audience participation at all. The question and the Q&A session would be at the end of the 4 presentations when you can interact with the panel of speakers. And if you have any questions at all, you put them in the chat, and opposite that question, you put the name of the speaker to which you're going to address that question. And all of that is going to be collated, and in the Q&A session, we'll have your questions addressed to the speakers that you're interested in. Now, for those of you who are not as familiar with the chat, just jot down your questions. There'll be opportunities in the Q&A for you to just speak up and direct your questions to whoever you want to direct them to. So we'll go right into it right now, and we'll get the bios of the speakers read out and take it from there.
Mr. Klaus, can I go on?
Yes, sure. Please go.
All right. So we have Dr. Ike Muto here, graduated from the University of Ibadan Medical School in 1994, subsequently traveled to the UK for postgraduate training. His general practice training was with the London Gynecology undertaking at the St. Heliers Hospital in Charleston, sorry about that, He relocated to Alberta in 2010 and practiced emergency medicine at the Edry urgent care for about 9 years. He has further trainings in the University of Alberta in operational medicine. He is a certificate of the College of Family Physicians, CCFP, an associate member of the Canadian Board of Occupational Medicine, ACPOM. Welcome, Dr. Akimoto. Next
Thank you
one.
very much.
Dr. Emmanuel Abara. Dr. Abara is highly trained to treat disorders in the male and female urinary tract, bladder, urethra, kidney, and urethra, and the male reproductive system. Urology is classified as a surgical specialty, but since a wide variety of clinical problems are encountered when treating urological conditions, knowledge of internal medicine, pediatric, gynecology, and other specialties is required. Dr. Abara is certified by the Royal College of Physicians and Surgeons of Canada. He's a fellow of the American College of Surgeons, a fellow of the Royal College of Physicians and Surgeons of Canada, and a fellow of the International College of Surgeons, a fellow of the West African College of Surgeons. He maintains membership in numerous professional associations throughout the world, including the Canadian Medical Association, the American Urological Association, the International College of Surgeons, and the Canadian Urological Association. He is the chair of the Teleurology and vice chair, Digital Transformation Leadership Working Group of the International Society for Telemedicine and Health. He has taken interest in use of technology for improving access, care, and quality specialties to rural and remote communities. Welcome, Dr. Abara.
Thank you very much.
Dr. Jeffrey Goto. Dr. Goto is a urologic. Can this be? It's a bit too tiny for me. Don't worry.
You want me to read it?
Just to be increase it a bit more. The font. I will continue.
Okay.
Oh.
Yeah.
Yeah. Dr. Goto is a urological oncologist and clinical associate professor in the Department of Surgery and Oncology at the University of Calgary. He completed his undergraduate and residency training at the University of British Columbia. What?
Hold on.
What's going on?
There we go.
Okay. Okay, at the University of British Columbia, went on to complete his fellowship in urology oncology at Memorial Sloan Kettering Cancer Center in New York, and his Master's of Public Health at Harvard. Specializes in the management of prostate, bladder, and kidney cancer, and has expertise in open laparoscopy and robotic surgical techniques. Dr. Goto is a national key opinion leader in the field of urology, oncology, and currently sits on the Medical Advisory Board of Kidney Cancer Canada and Bladder Cancer Canada. He has served on the Scientific Program Committee for the Canadian Urological Association, CUA, and has been, has been named a CUA scholar. He is frequently asked to review submissions for a number of academic journals and has an impressive number of peer-reviewed publications. He has been an invited speaker at local, provincial, and national conferences. He has received numerous teaching awards from the Cummings School of Medicine at the University of Calgary and the Star Educator Award from the Department of Surgery. Dr. Goto is the founder and medical director of the Clinic for Advanced and Metastatic Prostate Cancer, CAMP, at Calgary's Prostate Cancer Center. He is also the principal investigator for a number of clinical trials in advanced prostate cancer. Welcome, Dr. Goto. We're lucky to have you. Next one, please. Yeah, Mr. Patrick Ajokura. Mr. Patrick Ajokura is a mechanical engineer and also holds a master's degree in supply chain management. He has had many senior level roles in many industries and many countries, including with Sherritt International, Enbridge Incorporation, Sunco Energy, Petro Canada, and Royal Dutch Shell. Patrick is presently the managing partner in VCM Supply Chain Venture. Until recently, he was the general manager in charge of operation and services at Sherritt. Beyond the work he does for operations, Patrick is active in the community. Until June this year, he was the board director of Calgary Catholic Immigration Society for 6 years, director on the board of Supply Chain Canada, Alberta Institute, and member of the SCM program committees of both Valley College and Southern Alberta Institute of Technology, president of the Nigerian-Canada Association of Calgary between 2021 and 2023. He currently serves as the Chancellor of the College Physician and Surgeon of Alberta and a member of the Award Committee of Supply Chain Canada. In 2017, Patrick was honored as the Supply Chain Executive of the Year in Alberta. And in 2018, he was awarded the Fellow of Supply Chain Canada. He is also a recipient of the 2022 Newcomer Recognition Career and Academy and 2023 Queen Elizabeth II Platinum Jubilee Medical Award by Alberta Provincial Government. So welcome, Mr. Etikura. I think we are so lucky to have all of you here this morning. Okay. I think we cover everything. So to you now, Mr. Klaas.
Yes, our first speaker is, can you help me there? My first speaker, who would that be?
I think that's myself from the...
Okay, good. Okay, then, but before, we want to thank all of you for the four speakers for taking the time to come and sharing your knowledge and experience with us. Managing four speakers on pretty well the same topic is a bit of a challenge. We've tried just providing focus where you can at least cover some important points, each of you. We recognize that there'll be overlaps and that you'll be bleeding into each other's information, and that's expected. But hopefully we can keep the presentations within the desired limits, which is 15 minutes, and then move on to the really important part of it, which is the Q&A. So we'll start with you, Dr. Mutter.
Thank you very much. Good morning, everyone. just like you rightly said, presentations are likely going to overlap. I'm a primary care physician, so I'll try and keep my my presentation quite minimal, really, because I recognize that Dr. Barra and Dr. Goto will most likely go to town on these topics because this is what they do every day. Okay, so I've got a bunch of slides, not a whole lot. I probably would not spend a lot on all of them, but let's go to the next slide, please. So my topic was supposed to be what is prostate cancer and its prevalence in African men. Unfortunately, like I said, I did not see the agenda until this morning, so I kind of put together things that would overlap, but I'll try and skip some of them. So before we sort of talk about what prostate cancer is, I think it's important to understand what the prostate gland is. And the prostate gland is the only gland that is unique to males. Now, I guess a few years ago, it would be taken for granted that, at least in my office as a primary care practitioner, like you would only sort of worry about prostate gland in people who come into you as a male. But, in the current world that we live in, you have to think about the prostate gland in people who are males, but who have transgendered as well. So if you look at this sort of slide there, hopefully it's clear, but if you look at that little thing that sits under your bladder, that is the prostate gland, and it's shaped like a walnut. And I suspect that, the name the Walnut Foundation is very apt because, the prostate gland is sort of has the size of a walnut, very small, just sitting underneath the bladder. So the diagram is quite clear. So we need to know prostate cancer. So this is the prostate and then cancer. Let's go to the next slide, please. So these are things that I found, sort of looking around to see what the data is. Second most common in men. I hope that is still true. 6th leading cause of cancer mortality in men, and the highest death rate in men of African descent. So, as long as you've got African blood in you, African Americans, Afro-Caribbeans, when they get diagnosed, they tend to have a higher death rate. Next slide, please. So again, like I said, I know Dr. Goto will be talking about symptoms, but basically you can have asymptomatic and symptomatic individuals. And asymptomatic individuals, basically this is where a lot of what we do in primary care comes in. And I know that, the specialists will be talking about screening guidelines and things like that. But I think in my practice, I've seen quite a few, and Dr. Goto, I've sent them your way sometimes. I've seen quite a few individuals who came in just for routine health checks and were found to have a high PSA and were completely asymptomatic. And I've also seen individuals who came in for routine checks with a normal PSA with a nodule on their prostate gland on physical examination. And a lot of these individuals were completely asymptomatic. And then you wonder, if they hadn't come in for their routine checks, would these have been picked up? Some of them are of African descent, some are not. But I think what I think is important to understand is when I look at people who are in the right age who are of African descent, I tend to have a lower threshold for screening them because I know that they are the cohort that tend to have a higher risk for having prostate cancer. Let's go to the next slide, please. Okay, again, this is just a bit of a diagram to understand how those symptoms of prostate cancer come about, like in the previous slide. So on the left side, you have a normal prostate. On the right side, you have a prostate that is big. When it's big, it reduces your ability to pee. So the pathway for urine flow narrows out, and that is when people become symptomatic. that is, when people become symptomatic with an enlarged prostate, those are the symptoms that they would experience. Difficulty to pass urine, waking up at night several times. I mean, there's quite a lot of symptoms that I tend to hear in my practice that are referable to the prostate gland. But I think the key for us as primary care practitioners is basically to think about it, to think about the individuals who are at risk, to think about individuals who present with these symptoms, whether the symptoms are just prostate related or whether they're related to some other disorders of the urethra, which is this pipe through which urine comes out. If I practice in Africa, for instance, there are other things that I think about, effective causes for some of these things. But in this environment, we think about prostate cancer. We also consider people who, especially new immigrants, where they're coming from. Is this prostate related? Is this infective? Is this urethra? But like I said, if you look at this slide, it tells you exactly what is going on, why people, when they become symptomatic, why they do. Next slide, please. So risk factors, basically. Age is a risk factor. Family history is a risk factor. Lifestyle and African descent. So when you have family history and African descent and age, it becomes kind of a toxic cocktail. I have seen patients in their early 40s or late 30s, as a matter of fact, African descent with a family history, right? So you do get some of these individuals who come into your office, and that is why we as primary care physicians, it's important for us to recognize this, because a lot of these patients would not just walk into the specialist center looking to see a urologist. They almost always come through the primary care doctor's office, except for those who present in emergency, who have not been seeing their doctor for a while, who present in emergency with an inability to pass urine. That is when the specialists, see them. But almost all the cases, again, Dr. Goto and Dr. Barra, I'm sure you will testify to this, always come via referral through some other practitioner. So I think that, our job as primary care physicians is quite huge in trying to recognize these individuals and catch them earlier as well. And, also educating them, about the need to get screened, as it were. Next slide, please. So I was looking through the sort of the literature to see what I could find about the prevalence of prostate cancer in Nigeria specifically. When I was in medical school in Nigeria, a lot of the prostate diseases that I came across were always people who advanced cases, basically. I had memories of the prostate clinic as a way of men walking in with huge bags of sort of catheter bags, and I had what they call a bougie clinic, where they always have to go get bougie, put a steel rod through their urethra to sort of open the pathway up. So Professor Segbe in his book did a prospective study of Nigerian men 45 and above with prostatism, and they found that the mean age for prostate cancer, at least in that study, was 68 plus or minus 10 years. And they found that they had predominantly advanced disease. Now, when he did this study, he found that this study was also comparable, because I think there was some talk in the literature about the incidence or the prevalence of prostate cancer in Nigeria not being as high as what you find in the US or in North America or in Europe. But actually, and this study was an in-hospital study, but actually what this study also showed was that this was not being diagnosed. Basically, people were not presenting, or they presented late in the disease. So the prevalence is actually comparable. So the prevalence in Nigerian men is comparable to the prevalence of African men in the US in North America and in Europe. So that was what this study wanted to highlight. And they found that 64% of them died within 2 years. And that's because they presented in an advanced case. And bear in mind, there are other things that go into this. You know, the availability of new medication, the availability of surgery, the skill set, and all that. So, but this was what I could find in the literature. Let's go to the next study. Next slide, please. Okay, well, this is just about diet, and I'll just leave this. I'm not just going to talk a lot about this at the moment. I'll just leave this for that. So, yeah, you can just go to the next. I think that is the end of my slides. So like I said, I didn't have a whole lot of slides just because I wanted to keep it a little bit high level and let Dr. Goto and Dr. Abara do their bit. And then maybe when we get to the question and answer session, maybe I might be able to contribute more. Thank you.
Thank you very much, Doctor. I'm sorry I have to rob you of a spontaneous sort of questions at this point, but I'm sure
that's okay.
Later on. Okay, now our next speaker is Dr. Gatto, and let's just hear from him.
All right. Can everybody hear me okay?
Yes.
Excellent. So yeah, thank you very much for the invitation to speak today, and I'll keep it relatively brief, and there will be likely some overlap with what Dr. Moto just presented and what the next speaker will be discussing, but yeah, I'll do my best to keep it brief and yet somewhat comprehensive. So similar slide to what Dr. Moto presented, just showing sort of the anatomy of the male pelvis and where the prostate is located. You can see the prostate is sort of the pink organ in the middle of the screen there. And as Dr. Moto mentioned, many of the symptoms that men have related to their prostate are attributed to the fact that the prostate surrounds the urethra and as a result causes constriction or compression of the urethra as it enlarges or as tumors develop. And that leads to various types of urinary symptoms that men might have, whether that's, difficulty in peeing or peeing very frequently, or even blood in the urine, and this sort of thing. The difficulty there is that a lot of these symptoms that develop related to the prostate do develop as a result of benign or non-cancerous enlargement of the prostate as well, and not necessarily relate to prostate cancer. So it's very common for men in their 50s, 60s, and later in life to come in and see their family physician for various urinary symptoms that most of the time do not relate to prostate cancer. Most of the time, those symptoms relate to, again, BPH or benign non-cancerous enlargement of the prostate. But nevertheless, those symptoms do require some amount of investigation. And as Dr. Moto mentioned, a lot of that investigation will involve a rectal examination with the finger to feel the prostate, to check for any nodules or abnormalities. And then often a PSA test, which is a blood test that's quite helpful in identifying prostate cancer early. So I touched on some of the signs and symptoms of prostate cancer, again, being urinary symptoms. Again, the prostate anatomy and where the prostate is located not only dictates the signs and symptoms that men have as a result of prostate cancer, but also how we treat prostate cancer. It's a difficult organ to get to in the body, so surgically it can be challenging to remove. We do those surgeries either open through a small incision in the lower abdomen or with a laparoscopic technique with a camera and a robot assistance to allow us to get to the prostate. Likewise, we have radiation therapy and other treatments that will be discussed later in the day that are able to target the prostate. The other thing to keep in mind is that the structures surrounding the prostate, so the bladder that you can see in the diagram there and the rectum sit right beside the prostate. And so the side effects of these treatments are sort of dictated by basically damage to those structures as a result of surgery or radiation therapy. So incontinence or leakage of urine or irritation of the bladder or urethra, scarring, stricturing, narrowing in the urethra all sort of relates to where the prostate is located there in the pelvis. So things to know about prostate cancer. As Dr. Moto mentioned, it's a very common disease. It's probably the most, if not second most common cancer diagnosed in men. That being said, it's a very slowly progressive or slow growing cancer the majority of the time. In fact, with screening, with PSA testing and techniques, we often identify prostate cancer so early that it does not require treatment when it's first identified and can be monitored with surveillance. Some of the risk factors that were touched on include age. So the older you are, the more likely you are to develop prostate cancer. Race and genetics do play a big role. So we know that Black men are more commonly diagnosed or more commonly develop prostate cancer. Certainly family history, especially if you have a first-degree relative like a father or brother who's had prostate cancer or other related cancers like breast cancer. In women, you can be at higher risk for developing prostate cancer over time. And then there is some evidence that diet and obesity play a role. It's not totally clear what type of diet, but certainly, as Dr. Moto mentioned, probably the Mediterranean diet is considered quite healthy, and lots of fruits and vegetables, fish, this sort of thing, trying to avoid excess carbohydrate, sugar, and maybe red meat. But it's not totally clear what specific dietary factors are involved. I was mostly asked to touch on sort of signs and symptoms of the disease, which I mentioned in that sort of brief anatomy lesson at the start there. But I just wanted to make the point that really with prostate cancer, men don't tend to develop symptoms until very late in the disease. And typically men who come in with symptoms related to prostate cancer can't really be cured of their cancer. So if you come in, bleeding from a prostate cancer or with pain in your pelvis or pain in your bones related to metastases or spread of prostate cancer, it's typically at a stage then that all of our treatments are really palliative and we're slowing the cancer down but not able to cure it. That might not be true for some of the other urinary symptoms that men develop as a result of prostate cancer, but again, those are more likely to be attributed to benign growth or BPH in the prostate. So the point here is that it's important to have screening for prostate cancer with PSA testing to try to identify it early before you have symptoms and while it's still at a treatable stage. The PSA test is a blood test that's done different ways depending on what screening protocol is being followed, but often it's an annual blood test that's done in men starting at least age 50. And some guidelines recommend that in Black men or men who have a family history of prostate cancer, that it be started earlier, maybe at age 40. Another important test to be done along with the PSA is the digital rectal examination, and that's done in the same intervals as PSA testing. And it's important to note that some men with prostate cancer will have normal PSA levels, but still have significant prostate cancers, which can be identified with rectal examination. That's probably upwards of 20% of prostate cancers, where you'll feel the cancer on the rectal examination, but the PSA is actually normal. So it's an important part of the screening practice as well. So yeah, PSA testing has improved our ability to detect these cancers earlier. Probably 20 or 30 years ago, when the PSA test was first introduced, it actually caused us to identify cancers too early. And so back in the 90s and early 2000s, we were picking up all these really low risk cancers that didn't really necessarily need to be treated. But we didn't really know that back then. And so I think that led to a lot of over treatment of prostate cancer in the past. And as I mentioned at the start of my talk, that's less of an issue now that we're doing what's called active surveillance, where we're watching a lot of these cancers, at least when they're diagnosed early on. I was asked to talk a little bit about different types of prostate cancer. So I thought I'd touch just briefly on staging of prostate cancer and how we risk stratify men. So when we talk about at least the tumor stage of prostate cancer, really what we're talking about is how big is the tumor and can we feel it on the rectal exam. We also talk about grading of prostate cancer and basically how aggressive it looks under the microscope. And that's based on a Gleason scoring system. This is the tumor staging here. So you have a tumor stage or T stage from 1 to 4. And again, it's based on how it feels on rectal examination, or in some cases, how it looks on an MRI. And you can see in a T1 tumor that typically you can't really feel it on the rectal examination. It's so small and imperceptible. On a T2 tumor, you can feel a hard area in the prostate, but without any evidence or sign of it having spread beyond the prostate. And then in a T3 tumor, you can feel the cancer on the rectal examination. You can feel it outside the prostate into the structures around the prostate called the seminal vesicles, or at least going through the capsule of the prostate. And then in really late stages of the disease, where men tend to be more symptomatic, again, like I mentioned, with blood in the urine or difficulty peeing, that's often related to what's called T4 disease, where the cancer is actually invaded into the bladder or pelvic floor or rectum. And then grading, I mentioned. So grading is basically how the cancer looks under the microscope. It's an indicator of how aggressive the cancer is going to behave. So the higher your Gleason score or Gleason grade group, the more likely your cancer is to metastasize or spread or even recur after treatment. This is basically just some description of how the Gleason score is calculated, but it's basically a little bit confusing, but you get 2 scores out of 5. The lowest score you can have if you have prostate cancer is a 3 out of 5. And the 2 scores relate to the most common pattern of cancer seen under the microscope. And then the second score is the second most common or other type of cancers identified. And you add those scores together and get an overall score. So you can see in this example, the patient had an area of Gleason 3 and an area of Gleason 4. And so their total score was Gleason 7. And now we're using something called the Gleason grade group, where Gleason 3+4 would actually be called grade group 2. And yeah, so based on the tumor stage or T stage and the Gleason score and then the PSA, we kind of classify men into different risk groups: low, intermediate, and high risk. To be in a low risk prostate cancer group, and these would be typically men that we would offer surveillance to, so monitoring of their cancer, you need to have a PSA less than 10, a Gleason score of 6 or less, so basically the lowest Gleason score you can have, and then a T stage of T1 to T2B, meaning you either can't feel the cancer on the rectal exam or that's only on one side of the prostate, but not outside the prostate. So if you have all 3 of those factors, you're a low risk patient and you can probably be safely monitored with surveillance. If you have any of these factors, you become an intermediate risk patient. So if your PSA is over 10 but less than 20, if your Gleason score is 7, or if you can feel the cancer on both sides of the prostate, if you have either one of those 3 factors, then you're an intermediate risk prostate cancer patient. And in the majority of intermediate risk prostate cancer patients, will recommend treatment unless they're elderly or have other sort of what we call competing risks, where we think they're more likely to die of something else in the next 10 years than their prostate cancer. And then the high-risk patients are the ones we worry about. These are patients who have very high PSAs over 20, or a high Gleason score, an 8 to 10, where it's an aggressive-looking cancer, or in a cancer that we can already feel outside the prostate. And these kinds of patients require treatment. It's often aggressive treatment, combinations of surgery, radiation, hormonal therapy. Often when men come in with really high PSA levels or these other features, we'll find that the cancer is already spread beyond the prostate, and really all we can offer at that point is hormonal therapy, chemotherapy, and this kind of treatment. So again, it's important to be identified early with prostate cancer so that we know it's there and we can treat it early and avoid these kind of high risk presentations, which have higher mortality rates. And I think that's it for my talk. Yeah, I'll end it there and turn it over to the next speaker.
Aye. Can you project my slide? Anyone? London. Yeah, good afternoon, everyone. Thank you again for inviting me. I'd like to recognize my colleagues who are here. Now, can somebody project my slide for me? Next slide. Next slide. I have no conflicts of interest to declare. These are my disclosures. I'm a community urologist, but I do teach at the Northern Ontario School of Medicine, University. Next slide, please. So I thought over the next 10, 15 minutes, I hope at the end of my talk, we'll learn about screening for prostate cancer, consider prostate cancer prevention, analyze treatment options available, and then scrutinize what I call the lens, the black man's factor in prostate cancer. And within this period, I would like to share some information about some of my patients as they've allowed me to present their cases. Next slide, please. So what is prostate cancer? What is the prevalence? Who is affected most? And who bears the burden? I think we've all heard it in the last two, through the last two speakers. Next slide, please. Next slide, please. So screening whole population, or you call it disease detection. Now, when you screen, you have to look at the cost of screening. And currently, one would consider disease detection a better way to look at this condition in terms of cost, in terms of appropriateness, and there are so many guidelines from the various national or international organizations about screening. Now, what are the tools for screening and disease detection? Previous speakers have talked about this. Currently, we find that digital rectal examination, PSA testing are good. But quite importantly, particularly for our primary care physicians, digital rectal examination and proper family history would be very good and can be very cost effective in early detection of the disease. Now, when you think of PSA, we've had a good talk on PSA. And we look at the fraction, free and total PSA ratio, as one factor that helps us in suspecting prostate cancer, and that helps us in determining who gets a biopsy, who does not, when you put other risk factors in place. Next slide, please. I'll share with you the first case. A 73-year-old gentleman of African origin referred for evaluation of the lower urinary tract, had a positive family history in the father and 2 paternal uncles. His lower urinary tracts were mainly due to overactive bladder, so he got some anticholinergics. But because of the family history, we decided to do PSA. And his initial PSA was 4.9. Again, we repeated it, it went to 5. Then again, it went to 5.8. And in fact, I saw him yesterday, and he had the most recent PSA at 4.9. And then the total PSA was 0.10. So when you look at what the laboratory sent to us, his risk factor or risk ratio of getting prostate cancer is about 44 to 64%. And you ask yourself, what do you do? He's got a high risk factor, but he's not quite ready for any type of intervention. And so after we had a long talk, about 1 hour in the office yesterday, we agreed to continue with watchful waiting and monitor the PSA every 6 months. And if the PSA begins to rise, then he will have to reconsider all the options. Next slide. So what do we do in terms of prevention? As my colleagues have talked about, there are causes. If you have a disease, you need to know the cause. If you don't know the cause, you have to look at risk factors. And the risk factors have been outlined: age, race. We have higher levels in Blacks than Caucasians, higher levels in Caucasian than Asians. And like I said, family history is very vital. If a father or a brother has had prostate cancer, the risk is twice. And actually, if 2 close relatives have had the condition, the risk even increases. But if you go back to the first patient I am looking after, we're working with him, one would say, why are you delaying doing anything? And this is one of the things I want us to look at, apart from the condition, the dialogue we have with our patients and the dialogue the patient has with the family. The other risk factor which we know is diet. There is a risk increase in Asians who have moved from Asia to North America, adopting the North American diet. And that's where fat intake and prostate cancer, and then the vitamin D evidence or lack of vitamin may increase the risk. Next slide, please. So we know that there are sophisticated theories about chemical reaction in our body, defense against free oxygen radicals. The enzyme glutathione 5-peroxide and superperoxide dismutase and carylase are enzymes that help neutralize the harmful effects of these free radicals in our body. And these are called antioxidants. And these antioxidants act as defense molecules. And so you will find that those who are marketing objects or materials to prevent prostate cancer will tell you, buy medications or substances that contain selenium, vitamin E, or vitamin A, or vitamin C, because they believe that these may contain antioxidants that could form defense of the body immune mechanism. Next slide, please. So you'll find in the market a number of food items that people encourage you to take, such as phytoestrogens, garlic, tomatoes. And I do know that some people were carrying out research on tomatoes for a long, long time. I don't think that it ever worked out. But we know that there is association of low vitamin D with increased risk of prostate cancer. Again, I would like to think that for us, we need to actually question some of these theories and ensure that we know or find better explanations to possible things that may result in prostate cancer. Consider hormone therapy as a preventive technique. Now we have various levels of prevention: primary prevention, secondary prevention, tertiary prevention. When the disease is diagnosed, we can actually control it with hormone therapy. We will not cure it, but it can give the patient a longer life and for him to carry on with normal activities. And this is where the role of testosterone, dihydrotestosterone, comes in. And a medication we use for enlarged prostates may actually help in controlling the prostate cancer. But again, the literature is quite controversial because there are also a population where these 5-alpha reductase inhibitors, in addition to reducing the volume of prostate, decreasing serum PSA, may actually help in manifesting the presence of prostate cancer. So there are many questions to be answered. And I'm going to look at 2 other cases. Next slide, please. This is a 66-year-old Black man diagnosed 10 years ago with prostate cancer. He chose to try alternative and complementary treatment. He's still alive today. Recently, I saw him 2 weeks ago because he couldn't urinate and he had to have a catheter. His PSA was now 77, and at the time he had a biopsy 10 years ago, it was 5.7. So again, he has lived with this cancer, no standard treatment, but he's taking his natural products and he's doing lifestyle changes. The only thing that brought him back to me is because he couldn't pee. And he's living with a catheter. Despite all talks, he wants to remain the way he is. But he's agreed for us to do a bone scan on the 14th of October. He will continue on the alternative complementary therapy. So what are the options available for our prostate condition? No, go back to next slide. So these are the options. My colleagues have talked about them. And the key thing about treatment option is what I consider, if there's no consent, there's no treatment. If there's no capacity, and there's no consent. And that brings me into the ethics of looking after patients, whether they're Black or white or Asiatic. There is to be a dialogue. We have to open ourselves, bring ourselves to the level of our patients to give them all the options, guide them as they make decisions of what type of therapy they would have. Radical prostatectomy seemed to have very good results in preserving life, but the quality of life that is preserved can be quite challenging and debatable. A man who is able to perform and then suddenly he can't perform. A man who is able to control his urination and suddenly he's had to wear diapers. But these are things that we as physicians and support group need to bring to the attention of our patients as we offer them various therapies. The same thing with radiation. Radiation is great, no incision, but it does have some pullbacks. And these are important things that we need to talk to our patients about. That these are there, but they do have consequences. And like my colleague in Calgary noted, there's been a big pushback in terms of why must we be operating on all cancer patients? And there is enough evidence to support watchful waiting as a proper way to deal with patients with good results. Also, there is a need for us to consider the use of alternative and complementary therapy. Like the first patient I presented, even though his PSA is 77, he feels good. And he's a very well-educated, he's an engineer, he's a very well-educated man, and he knows the literature of prostate cancer inside out. And that's something that I think we need to encourage, that a patient comes to my office, he's already educated himself, and we have a very good conversation. And this is what I think should be the case. And I thank the Walnut Foundation and the African Cancer people for promoting this, because with the dialogue between the health professionals, the patients, the family, the public, the outcomes are likely to be much better. Next slide, please. I'm looking at my time to make sure I don't overtime. Case number 3, no, go back to case number 3. This is a 55-year-old Black engineer on annual serum PSA, it was 6.5. He had no symptoms at all, healthy, no family history of prostate cancer. It was very difficult to convince him, but he did feel strongly that if repeated PSA were normal and rising, maybe something was going on. So he had a biopsy. He had prostate cancer, placing 7 to 8 out of 10. All the diagnostic imaging studies showed no spread outside the prostate. Again, we discussed treatment options. He chose surgery. He had successful robotic-assisted radical prostatectomy, alive, but 6 years post-op, the serum PSA rose to 68. And again, the treatment options were discussed with him. He's rich. Well, I wouldn't consider him rich, but I think he's well off, he's well educated, and we discussed all the treatment options, either getting injections or taking tablets every day, or subcapsular orchidectomy. And he opted for subcapsular orchidectomy. He's totally asymptomatic. He's carrying about his life in the way he wants it. His PSA have dropped back to therapeutic levels, and he continues with surveillance. Next patient. Next slide, please. This is a 57-year-old gentleman. He's a Black physician, elder brother to case 3, following the diagnosis of his brother.
Sorry, sir. I'm really sorry to interject. That's something that you mentioned. Can you please explain it? I don't want to miss it, please.
What is that?
The last, the slide before, please.
Okay,
Case
go back
number.
to yeah. Go back to the last slide. So the subcapsular orchidectomy is when we take out the part of the testicle that produces testosterone. I'm sorry, I should have done that. Now, this was what used to happen before the new medications came into being. Now, these new medications cost a few $1,000s, and they're going to take you for your whole life. And the choice is for the urologist or even a general practitioner or a general surgeon under local anesthetic within 30 minutes to make a small incision and take out part of your testicle that supports the growth of cancer. The cost is probably in North America would be less than $100. In Africa, it's probably going to be about $20. And what that does is what all the medications, all the injections that people take. And you can imagine when you miss an injection, you throw yourself into an anxiety state. So by this small operation, which is virtually forgotten, you can carry on your life with your PSA well controlled for many, many years. I don't know if I've answered your question. Did I answer your question?
Continue, sir, Dr. Abara.
Okay, next, go to case 4. Now, case 4 is a 57-year-old Black physician, elder brother to case 3, had his serum PSA because of the diagnosis from the brother. And that's where I say information sharing is important. And in our culture, we tend to hide things, particularly when it comes to health issues. Now, for the first time, his PSA was 7.1. Free and total PSA was 0.07, increasing the risk of presence of prostate cancer. He submitted himself to a biopsy. It was a Gleason 8 out of 10. Diagnostic information, no spread outside the prostate. Again, the treatment options were discussed, and he chose robotic assisted laparoscopic prostatectomy. He's alive and well, busy with his clinical practice, and the follow-up PSAs remain therapeutic. Next slide. So what I call the lens, the Black man factor in prostate cancer in Canada. And the questions I want us to think about, I'm not going to give you the answer, but are we doing it right? Should our men be paying for serum PSAs, whether they are Black or white? Are we open to learn who to screen, when to screen, or is disease detection a better option? In terms of prevention, what can we do best? We can share information among ourselves, and this is what the Walnut Foundation and African Cancer support groups are doing by getting people to talk about their condition, getting professionals to give us better ideas on how to go about that diagnosis and treatment. But more importantly, in terms of prevention, we may not be able to have the prevention, but we can impact the risk factors, and those are important things we can do. Research and questioning current concepts about the unusually high prevalence of prostate cancer in Black men requires us to be more diligent in terms of primary, secondary, tertiary prevention. Next slide. Next slide, and I think I'm going to be done. So we have to think of all the options. There are myriads of them. Are these acceptable to all? Is there equity? And the choice is open for guided decisions to be made. Like I said earlier on, no capacity, no consent treatment. It is not like one cap fits all. What I've seen in my many years of practice in urology is that each patient is unique, and we need to attend to the unique needs of that patient. Like all my colleagues said, early detection pays off well. Professor Segbe, when he did his study in Nigeria, 64% of the men died within 2 years. Now, I have patients, and my colleague can attest to that, living over 25 years following either radiation therapy or radical prostatectomy or hormone therapy. And this gentleman that is still on complementary therapy, 10 years following his diagnosis, is somebody to tell us that it's not every prostate cancer that is lethal. It's not every prostate cancer that requires surgery. It's not every prostate cancer that requires hormonal therapy. Watchful waiting can get good results. Next slide. So we've come a long way. We know more about prostate cancer. If we cannot prevent it, we can detect it early and control and live. So where is the family support? Very important in the management of cancer of the prostate and cancer everywhere and disease everywhere. The cancer affects the family. Cancer impacts the community. We should come together to overcome the challenges of prostate cancer. Thank you. Next slide. And acknowledgements to Oladele Foundation, Africa Center, Walnut Foundation, and all of you who have joined and participated in this panel discussion. Thank you very much.
Thank you.
I was on time.
Thanks, Dr. Barra. Thanks for a very interesting presentation. Our next speaker is Patrick, and I hope I get this right regarding pronunciation, Etokudo. And please, Patrick, please go ahead.
Thank you very much, Mr. Callas. Are you able to hear me now?
Yes.
Yeah, my apologies. My laptop gave up on me, so I'm using my cell phone now. But glad you can hear me. Well, first of all, I just want to say thank you to the Oladele Foundation. Of course, the African Cancer Support Group is part of that organization, and the Walnut Foundation as well. I think this is, I think it's probably the second or third time that I've been on a panel that the Oladele Foundation has put together to address cancers in generally, but this is the first one that is specific to prostate cancer. And so just from the stats that my well-esteemed co-panelists who are experts in the field have shared, it is clear that those of us who are black-skinned and come from the African continent one way or another need to be extremely aware of what's going on and how we can take care of ourselves. And so kudos to both organizations. You know, I always start my story on these panels with my personal story. And that is the fact that my father died in 2016 from prostate cancer. So this is pretty close to home. If you think about the two groups, or the two, I think Dr. Muto called them the sort of catchment groups. I'm African, and two, I have a family history. And so I'm high up there in terms of exposure or potential to have prostate cancer. So I want to, acknowledge all of the speakers who've gone before me, who are clearly experts in the medical field, including, of course, Dr. Godo, who happens to be my personal urologist as well. And so I start this story because I need people. One of the things we struggle with, and I think Mr. Klaas started that conversation, is as Africans, for some reason, we still have a lot of stigma associated with cancers, which has nothing to do with us, so to say. It's not that we did anything wrong or committed any crime, but for some reason, we still have a lot of stigma around cancers in Africa. And so I start with my personal story. My father had enlarged prostate. It was considered benign. Way back in 1995, he was about 62, so I'm slowly getting to that age. And so he underwent surgery. We thought that was it. But in 2012, when he was 79 years old, he was diagnosed with prostate cancer, despite the surgery that he had way back in 1995. And finally, the cancer took his life 4 years later in 2016. Also, as you listen to Dr. Abara talk about the various cases that he presented, first of all, my father was advanced in age, so certain of the options were not really viable for him at 79. But also, I like to say that my father was a very stubborn man, and he refused most of the options that were offered to him. He decided he was just going to go through it all, and he thought, well, he's at the end of his life, he might as well live his life to the fullest until he left. I shared with anybody who listens to this story that my father said that the one prayer he was making before he died was that none of his children should ever go through what he went through. That the pain associated with prostate cancer is something that he would not wish his enemies. And so I think it's extremely important for us as a community, but also as individuals, to be aware. And you know, an event like the one we're going through today is a big eye-opener for us. And so thank you to both organizations. But what can we do as an individual? As you listen to this, clearly, if we all live long enough, at some point, it's very likely that we would get prostate cancer as African men. And so it is important that we are self-educated, that we are aware. And so I thank all those who are able to join the conversation today. We struggle to get people to be interested in these things. And unfortunately, people shy away from it until it's too late. And so self-education is important. Attending events like this and listening to those who know is important. Leaning on organizations like the African Cancer Support Group. We don't have to wait until we have cancer to lean on them, to be educated, to be informed. As men, we often get together and have conversations about most things. And so as individuals, I think we need to include the conversation around prostate cancer in those discussions that we have with our fellow men. It is things like that that will start to move the bar on stigmatism and start to bring it nearer home for folks. When we share our experiences, talk about our observations, share what we've heard, know, or read of, and just have the conversation. I think Dr. Godo also spoke to the fact that regular checkups are important. I think he talked about 50 for most, 45 for those of us who belong to some of those exposed groups, like we're black skin, we are up in our age, and we may have family history. You want to probably start your checkups at about 50. I've also seen elsewhere where they've suggested that, in fact, you should be having those conversations with your primary providers, like Dr. Moto talked about, from age 45 even, or maybe even 40 if you so desire. And so one other thing that I think we need to do is the habits that our medical colleagues just talked about right now. Trying to eat healthy, making sure that we exercise, and that we give ourselves sufficient rest. I know in the busy world today, the pressures of taking care of ourselves, our families, extended families, because we're of African origin, puts a lot of pressure on many of us, working several jobs, no time for exercises, we hardly sleep enough. Those are poor habits when it comes to prevention, or at least mitigation of some of the potential for prostate cancer. And as much as possible as individuals, let us provide support to those we know need it. either collectively or as individuals. I think we have personal obligation to look after ourselves. I think that's taken for granted, but I believe that we also have the obligation to look after those who are near and dear to us. And so I want to speak briefly about us as a community and what we can do as a community. And so I took just some notes as the medical professionals were speaking about. And I thought about the stigma that goes with cancer. And I know it's not specific to prostate cancer, but this is one of them. If you read between the lines in some of the conversations, some of the treatment for prostate cancer might mean that we may be looked at as less than men because we are no longer able to perform in the other room as we normally did, depending on what the form of treatment is. And so even the stigmatism that goes with it, with prostate cancer, is extended by that conversation itself. I think it was Dr. Abara that talked about wearing, what is it called? Some form of pad to prevent leakage when we dress up, right? So all of those things seem to make it even more, people don't want to talk about this. People don't want to accept the fact that we're all exposed. And I always take the opportunity to say, hey, I'm number one, I'm getting to that place. And that is the reason I see Dr. Godo every 6 months to make sure that it is going down south. He catches it on time, right? And so I encourage us as a community to talk about these things. I remember as president of the Nigerian Association, we actually ran a session way back in the day, and we brought experts, medical doctors. I believe Dr. Moto was actually one of them to talk about some of these medical cases. And part of it is just to say, listen, it's okay. You're not the only one. We are not the only people. We may be 2 times the rest of the population in terms of prevalence, but it happens to all of us. It happens to everybody. I actually read, and I don't know how scientific this is, but I read some studies somebody published years ago that plotted the discovery, because it does appear it's always been there, it just wasn't discovered until the PSA as a methodology came through in the, I believe, late 90s is what Dr. Godo mentioned. But they started plotting the discovery and it looked like the graph just went that way. The good thing is, from what the individual published, that the death rate associated with prostate cancer also came down as advances in medical practices also came along. But anyways, if they extended that graph the way it was going with no correction and nothing to bend the curve, it would suggest that by 21 some years in 22nd century, every single man would get prostate cancer. Of course, we hope that's not the case. We hope there will be discoveries and inventions and stuff to bend that curve and to correct things. But we need to share these stories, to own our stories and make it personal so that other people can step forward and also share their stories. But more importantly, that we encourage the younger ones coming after us to talk to their doctors, talk to the medical staff and get the support, the prevention, the diagnosis early, so that we do not have to bury each other and for in an untimely manner. I mean, Mr. Klaas shared his story. That what a great example. Not only did he overcome the cancer, he's now using his time to make sure that the rest of us are aware of it. The other piece that I think we need to do is how do we provide support to those of us who are already caught by this disease? And so individually, but also through organizations like the African Cancer Support Group, we can donate money that then supports those of us who already are affected. Information sharing is another big one. Every opportunity that we have, I think we should share information and we should advocate very strongly for those who are going through the disease, but also for the organizations that are helping those who are going through the disease in every forum that we find ourselves. There are government grants going to all sorts of things these days. Why wouldn't we advocate for a lot of those grants to go towards causes like this? And so as a community, I do believe strongly that we do have a role, especially if you provide leadership one form or another to a community. Those would be my thoughts from a community perspective, and I'm happy to take any question that comes with it. Thank you so much.
Very good. Excellent.
Thanks very much, Patrick. We've come to the end of the presentation part of it, and we're moving into the question and answer. And Patrick, that was your sentiments emotionally are very much aligned with the way we feel at the Walnut Foundation, the community responsibility and everything. So thank you for taking our message out the way you did. We first are going to address the questions that have been inserted in the chat. And then after that, it'll be open for questions from anybody in the audience. So let's see what we have in the chat first, and then we'll go through that, and that's how we're going to proceed. Did I
I'm going to project the questions now.
Okay, good.
So while she is trying to project the question, I think Thomas Banks is
Okay.
Yeah. Can I come in now?
Well, I think we're on to the first question, so we might as well proceed that way. And then Mr. Banks, then we can get you afterwards for sure. So the first one says, when you say that the mortality of prostate cancer is higher in Black men, what are your assumptions about the causes? Genetic versus social inequalities. It wasn't directed to any one member of the panel. Is there any one member who would like to answer this question?
Let me just take a bit of a shot at this question before I hand over to Dr. Gupta, Dr. Obara. So I think when it comes to cancer, excuse me, when it comes to cancers as a whole, there are certain genetics about cancer in terms of those who are predisposed, those who are at a higher risk. And so I think the question basically, and help me just to make sure that I'm getting this right. When you talk about genetics versus social inequalities, maybe you mean about poverty, is it the Black people, their incidence rate or their prevalence rate, does it have anything to do with their social standing in the society? The answer is not necessarily that, because there is a genetic predisposition for being a Black person, just like there is a genetic predisposition for being a particular racial group for having certain diseases. These are things that have been studied over many decades. So then in the causation of cancer, there is the concept of nature versus nurture. So nurture would mean your genetics, nature would mean your environmental factors. So if you have an individual who is so predisposed, who eats unhealthy, is obese, who smokes and all that, then you have those two combinations vastly increasing their risk. So, being at risk from prostate cancer as a Black man has not a whole lot to do about your social standing, but it can have something to do. But I think it's more about the genetics, about the predisposition. Thanks.
Any other responses? Any other responses? No?
Yeah, I could speak to that as well.
Okay.
I agree with everything Dr. Moto said. Certainly, it's always a combination of genetics and social factors, and I think we've established that Black men do have a genetic risk factor for prostate cancer. We know that even when screened appropriately, when we identify prostate cancers in Black men, they do tend to have higher Gleason scores and maybe more likely to behave badly and metastasize and this sort of thing. But then likewise, one of the other things that comes into play is social inequalities and maybe lower access to healthcare. Maybe not so much of an issue in Canada in our healthcare system, but I think certainly in the US. A good friend of mine who I trained with in New York is a urologist and also happens to be Black. And I've spoken with him about this many times, and he's quite an advocate for prostate cancer screening for Black men in the US who often, because of the inequities in healthcare in their system, don't have access to a family physician and don't get screened as often as they should be, and this sort of thing. So I think one of the reasons that mortality rates might be higher is that we identify the cancers too late, because Black men may be less likely to have appropriate screening and may come in with symptoms. And as I discussed in my presentation, if you have symptoms for prostate cancer, it's often too late. If you show up with back pain from a metastasis in your spine or blood in your urine because your cancer is invaded into your bladder, it's too late for us to cure it at that stage. So I think it's a combination of genetics and social factors which need to be addressed for sure.
I would like to add to my colleagues' comments. It's a combination. In fact, these are not assumptions, they're realities. We have enough data. There are studies to support this statement. In addition to genetics, in addition to inequities, there are cultural things that make people not to come forward, not to seek help. Even though they may not have family physicians, sometimes, there is this sense of being a your man. Nothing will touch you. These are things that stop people from seeking help. And when eventually the symptoms set in and they want to come for help, it's too late. When Professor Osegbe of blessed memory published his paper in 1997 from Lagos University, it was his experience and an experience that people were coming to care when they had metastatic disease. You couldn't even offer them radical prostatectomy because the stages were late. And some of them were well-to-do. Some of them were well-educated. But there was this cultural thing, the man thing, that stopped people from coming forward. So in addition to genetics, which of course carries a big risk, the inequities that surround even the care we provide in a country like America, country like Canada, don't talk about countries in Africa that healthcare is not available. So it is a reality, the combination that really we need to advocate for. And this is why I say to my government, there's no reason why men should be paying for PSA, even if they have the money. Sure, if you're able to do something for breast screening free of charge, our men should get their PSAs free of charge, particularly if their risk factors are higher. I'll stop talking because I advocate for my patients, but that's
Yes.
my viewpoint. So a good question, and we need to continue the conversation. We need to continue advocating for our patients. We need to give our patients the opportunity to come out, tell us what they want. And I tell you, there are patients we've looked after. In fact, I just presented a case at the International Continence Society meeting 2 days ago in Toronto. A man that we did a radical prostatectomy in 1997. We thought it was localized disease, but he had a T3 disease, but he didn't want any formal therapy. Even though his PSA was dancing up and down, he lived for 25 years without treatment, but he was in a surveillance. So there are opportunities for us to create a change. There are opportunities for us to decrease the mortality rate by good understanding of the factors that impact on this. And this is why we should encourage groups like Walnut Foundation, the African Cancer Support Group, and the community to come forward, share information, and let's stop this big challenge of the prostate cancer and other cancer conditions and mitigate them. Thank you.
I just want to briefly touch something because it addresses a point that is made at our Black support group. And there's been a buzz over the last 2 to 3 years in the United States about the incidence of mortality when there's pregnancy problems among Black women. And it's 3 times higher than among any other women. I'm not pointing fingers here, it's just where it is. I mean, there are tribal biases, there are all types of biases, but where it nets out is that there are conscious and unconscious biases in the health system that operates against us Blacks.
Yeah.
And we have to address that in some way. The way we address that is if we're diagnosed, we have to go out there and do our own research and advocate for ourselves, because we have to be able to smell out when there's a bias there that is preventing us from getting to the best treatment. And we have to assert ourselves and make sure we get the best treatment. And this is just not throwing things out. This is something that is very important for us to do. It's in the health system. It's going to get better over time, but right now we have to live with that. Next question. Okay, talking about risk factors. So many contradictions about African descent being one of the factors. Do we have recent clinical trials here in Canada? If yes, how were the studies designed? And how was, you have to scroll up so I can see the rest. Again. Oops. Yes, and how, and it's just the next line I'm trying to get. And how was the Black population defined? Yes, okay. I hope you got a question, and well, members of the panel, well, I hope you understood what the question was all about. Just jump right in and if you have an answer for that.
Could I say something? I'm not a specialist, of course, Mr. Klaas. Sure, the experts would weigh in on this. So I think we talk about educating ourselves and we talk about advocacy and all of that, but I don't think that it matters to those of us who are not professionals how scientific the studies were, and and whether we question every little bit of the outcome of those scientific studies and analysis. I think for me, not being a medical doctor or a professional in that space, is to say there's preponderance of studies and research and evidence that is published out there. Would it be nice if I knew if, for instance, were Nigerians part of the Black population that was studied, how did they arrive at? Nice to know, but at the bottom line is evidence shows that the Black race, African descent, is probably 2 times the general population, the prevalence, right? And so I'm not sure we should be slowed down, or we should worry too much about how were the studies done. Trust me, the scientific community would question every research that is done, ask the right questions. I'm not saying that our colleagues on the panel should not share more information on this. I'm just saying we shouldn't let this get in the way of appreciating what we're going through as an African community with respect to prostate cancer and all of the insights and knowledge and information that is being shared today.
Can I just, sorry, Dr. Barra, go ahead.
Mm-hmm. Okay.
I thought Dr. Barra wanted to speak. Dr. Barra,
Yeah,
please
I
go.
was going to ask Dr. Goto if he had any comment, but to my knowledge, there are very few studies. I mean, I got a scholarship from the CUA to do in my clinical practice, but very few Blacks. It wasn't focused on Blacks. There might be few studies, but I don't know that there is enough. Currently, the Cancer Society of Ontario has given a grant, and this is again in combination with Walnut Foundation and a group of physicians in Ontario to look at, it's not just Ontario, but Winston, you can talk on it, to look at cancer of the prostate in Black men in Canada. And in my opinion, that's probably going to be a landmark study, as far as I know. There might be a few other things published, but nothing in the way that you're looking at it. And I challenge younger African urologists or even non-African urologists to read the literature and actually look at what the literature says, because myself, I have some doubts. I have questioned some of the things about vitamin D and melanin being in our skin and making it impossible for even people who have sunshine 24 hours to be deficient of vitamin D and putting them at higher risk for prostate cancer. If you're reading the literature, there are a number of theories that have come on. And I think younger urologists of African descent should look at this. Because in my opinion, prostate cancer is like a pandemic in Nigeria, where I come from. When I go home, every single 60-year-old or older may have features related to prostate cancer. And again, I'm sorry I'm in Canada, but I do know what goes on in Nigeria. So I think time has come for us here, being of the Black race, knowing that we are all going to be impacted either directly or from close relatives for us to put efforts into knowing more about the condition, breaking the inequities in terms of resources, ensuring that no immigrants who come to Canada or the US are engaged in this mission, not just for prostate cancer, but even for ordinary conditions, to ensure that our people, no matter where they are, get good health care, whether they are rich or poor. That's what we should all be continuing to do.
There's some good news to this. The Walnut Foundation is increasingly involved in a number of studies that directly involve Black patients. And a few of them have to do with Black prostate cancer patients. There is a genetic study out of the Princess Margaret Hospital because they're looking at the special strains of prostate cancer that are identified with Black men. And back to the delivery of health in the health system, we're involved in more than one study that involves asking Black men about their experience in the health system, where they suspect that they could have obtained better treatment or not. And then the conclusions from that study are fed to the government, and then that would influence government policy in the future. So there's some brighter lights that are starting to pop up in this direction, and they're realizing that there are problems with the Black population, and money is put behind it to get these, to address this. It's gone even further in Nova Scotia, where government policy, they have done their research and everything, and government policy is framed and targeted to the Black population, complete with psychiatrists and psychologists that address the mental stress that go with cancer and related afflictions. So there's something going on, and we're happy as being a Walnut Foundation to be involved in this program. Yeah.
I was
Next question.
I just shared a few or two publications in the chat there that might be interesting to some of you, just around prostate cancer incidence in Black men. One is a study from Ontario using a big population based database, looking at those sorts of risk factors, and specifically commenting that it's men from West Africa and some Caribbean countries who are disproportionately affected. And then the other publication I shared there was one that a friend of mine from the US, who's a urologist who also happens to be Black, was involved in the publication. There's a lay summary there. Basically, prostate cancer negatively affects Black men more than men of other races. The history of segregation and mistreatment in the healthcare system might contribute to mistrust among Black men. Outcomes are worse for Black men because they are less likely to be screened or to receive treatment for prostate cancer. Again, I think that's more of an issue in the US because of some of the socioeconomic factors that we discussed. Black men are also unlikely or less likely to participate in clinical research, making it difficult for investigators to understand how Black men are affected by prostate cancer. Suggestions for addressing these differences include teaching physicians and nurses about issues Black men experience getting treatment, and improving how Black men get information on prostate cancer.
Thanks. We move on to the next question. A woman wants to know her son's risk level if her dad has had prostate cancer.
Being a Black man, we already know that the incidence is higher. Again, I was just looking up some numbers there, and I got one study showing that the overall incidence of prostate cancer in Canadian men is around 1 in 7, and for Black men, it's 1 in 4. Remember, that's diagnoses of prostate cancer, and that doesn't necessarily mean that it's again a prostate cancer that needs to be treated, or that it's a prostate cancer that's life-threatening, but certainly higher incidences in Black men. And then we know that family history, so having a father who's had prostate cancer does put you at higher risk. I think Dr. Ibarra quoted the number there, but I believe it's a 2-fold higher risk. So certainly higher risk, and recommend PSA screening for her son, at least starting at age 40. And then the other question about if your PSA level's normal, how often should it be measured? It sort of depends which guidelines you look at, but if you're over 50, probably once a year. If you're 40 years old and you're a Black man, it should probably be checked once a year as well. There's some controversy about screening other men in their 40s and whether it needs to be annually or every few years until age 50.
Yeah, I would add to what Dr. Goto has said. For the lady, the answer to your question is that yes, your son has a higher risk of developing prostate cancer. And the guidelines in Canada, and I believe maybe somewhere in the US, is all Black people and those whose parents or immediate relatives have had prostate cancer should start checking from the age of 40. And that's an annual physical exam, PSA testing, and chatting with your family doctor. And we don't know. It's a good habit. And we feel that not screening everybody is cost effective, but in fact, when people who have risk factors, that's what we call disease detection. It's much cheaper, more efficacious, and the outcomes usually better. In terms of PSA levels, the current guidelines in the area I practice in Canada is people from the Black race or high risk group from the age of 40, you do your PSAs once a year. And then others from the age of 50, you do your PSAs once a year. And remember, there's less than 1% of people who may have normal PSA but still develop prostate cancer. But again, that's something because people just have to do. And times change. So the key thing is to get yourself well educated, ask questions from your family doctors or your healthcare professionals, and get information yourself too.
Okay. Should we move on to the next question? And it's to Dr. Goto. And you can read it. How will we help in prevention and detection of prostate cancer due to the keeping silence about the symptoms? I'm missing some of the words here. Yeah.
Yeah, that's a great question, and something I mention often in my practice. And Dr. Moto might have something similar to say, but I think if you ask family doctors, the most common reason that men come in to see their family is, or their most common presenting complaint is, my wife told me to come in. And it's kind of funny, or maybe it's a bit of a joke, but it's true a lot of the time. And what is also true is that there are studies in the public health literature that show that men who are married are more likely to live longer than those who are not married. So we're very fortunate to be to have wives or partners who look out for us. And it's true that a lot of men don't seek help, not just Black men, but all men are less likely, I think, to show up to see their family doctor or to seek help. We need maybe reminders. Like my wife usually tells me to go see my family doctor too. And that reminds me I'm probably overdue to get my PSA checked. But yeah, I think wives are really important, and supporting their partners and being screened appropriately and leading healthy lifestyles. Encourage your partners to exercise and eat healthy, and see their family doctors, and encourage them to talk about their symptoms if they have symptoms. And certainly we know that men who've been treated for prostate cancer, really wives and partners play a huge role in recovery from treatment and support during that time.
Just in additional comments, one of the reasons I shared the two cases of the brother, the elder brother and the younger brother, was where I think any illness, even in the family, even if it's not cancer, just by sharing the information in an understanding manner, in a caring, empathetic manner with loved ones, wife, family, makes a great difference in the outcome, psychologically, or even clinically in terms of outcome. I agree with you completely, Dr. Goto. The wives are very supportive. They actually make the diagnosis sometimes even before the man shows up. And in my practice, it is the wife that makes the appointment. It's the wife that calls if the man misses the appointment. It's the wife that sets up the appointment if was a need. So, and that's one of the things about, in terms of primary, secondary prevention, our family, our community, we have to work together.
Can I just say something here? Dr. Berry, I don't know what your experience has been with this, with what you just said with respect to the wives being the ones doing this. But what I find in my practice is, yes, Dr. Goto, you're right, but it's much more the non-African wives who do this, who send in their husbands to come and see the doctor for, for a checkup and stuff like that. So there is something about the paternalistic nature of African marriages, which is which hinders this practice in Africa. And I'm not talking about Black people now. So I'm talking about people of African origin who grew up in Africa, not Black people who grew up in North America. Those practices are quite different. So I think for us as African men, or African men who are in marriages, or African wives who are listening to this talk, I think there's something to be learned from from what from the marriages in North America or in Europe. It's a bit different. So Dr. Barra, I don't know, when you say that is the wives, where are they from?
Well, if you want to know, the guy that has had his prostate cancer diagnosed 10 years ago, it is a wife that is making all the phone calls, because both of them have agreed that this is the way they want to be treated. So I hear you. I'm not trying to transplant Nigeria into Canada, but I think even the women in Nigeria, those of them who are, fairly educated, who understand, disease condition, they are quite proactive. I can tell you, our women are more proactive than our men, not just in disease conditions, but even in politics and getting things done. So you're talking about people in the village and who they don't even have access to good health care. They probably don't know enough of what is going on. But think about it. Who takes you when you were a little kid, if you grew up in Nigeria, who takes you to see the local dispenser? Who takes you to school? It is the mother, it is the wives. Just like they are here in Canada, they are doing the same in Nigeria. I mean, what is clear is that we men resist. We don't want to take it. But the women in Nigeria are doing the same. If they had the facilities that we have in Canada or in the US, they would just do it the same. Our women are very powerful. I tell you, they're more powerful than women in this part of the world. They may not show it, but they're there.
As you can guess, this topic and the ePanel discussion is very involved, and there's so many sides to it, and there are time limits, and I've been getting some messages there, and I'm trying to make some decisions here. We're past the end of our session here, and there's so many questions still to be answered. I really feel bad about this. But I'm hearing that. Hello? Did I hear somebody? Yes. But I'm hearing that maybe we might have to respond to the time factor here. But I would strongly advise the ones who arranged this, given the depth and the passion that was expressed here today, to provide an opportunity for this to be done, so that you have more of this interaction, and that is really sort of carried out, and people could manage to address all angles of this very difficult sort of condition called prostate cancer. I'm just going to make one brief couple of points. I mean, I'm looking at the time, and I know Mr. Banks had a question. I'm going to allow him to do it, do his question, and then I'll have to shut down after that. There is, and it came up in the last couple of speakers, there is a side of this that is very important, and it has to do with the mental stress, particularly among the macho men, because prostate cancer, it has to do with your prostate gland, which has to do with your sexuality. And manhood is very important to macho men. And prior to being diagnosed with prostate cancer, you'll hear all these rumors about men who have prostate cancer. Oh, it's because they had VD. It's because they had too little sex. It's because they had too much sex. Also, and then you get it. And then when you enter into a group, you wonder if they're all thinking the same way about you. So there's this mental stress, which is very important. And it has to be addressed too. I'm going to make a plug on October the 28th. That's where we're going with the Walnut Foundation. We're going to have a seminar around that, the sexuality issues and the mental stress, which is most important. And the second point I want to reinforce is that at sessions like this, is the women who come out and ask the questions. The men are very reserved for the very points that have been made before, and the ice has got to be broken a bit more so they can come out and emotionally express themselves. The women don't care. They love their partners, and they don't care if their questions are ridiculous, and they don't care if their questions address sensitive areas. They come right out and they ask the question. And they say when a man is diagnosed with prostate cancer, his woman is, because there are intimacy issues and all of that. And there's so much ground to be covered quite outside treatment that I suggest that we should have a repeat on this and an opportunity to investigate all of this. So I'll allow Mr. Banks to ask this question, and I'm afraid after that, I'm getting signals I have to shut this down. Mr. Banks?
Yeah, thank you very much, Mr. Klaas, and the other group for putting this event up. It's been very informative, I'll speak from the role of or perspective of a survivor as well. But I have three questions. One of them has been beaten enough, so I will leave that, but I'll ask these ones. There are many questions regarding PSA's capability as a tool to correctly diagnose PC. I've read so many pros and cons about it. So I want the experts on the panel to please explain, to tell us exactly where we are on that argument. The next question is, what is the role of sugar in any form of cancer? Because people are saying sugar kind of exacerbates the process of cancer gaining ground on you and things like that. What is the role of sugar? And again, I think education is very important, like we are having today, and most especially when we go to our doctors. I'm really sorry to say this. I don't mean to put anybody on in the spotlight, but I find out that when I go to an ACB doctor, I am more comfortable. I can ask more questions. They interact with me. They don't treat me as just a number, 5 minutes over. Come on, let's go. I have somebody waiting. In that scenario, you can sit down. Your doctors, I find out that my ACB doctor is even willing to tell me much more than I went in there to know. You know what I mean? Especially when it comes to all these things. But I believe if my doctor that I saw several doctors before I had my surgery, but if they had interacted with me the way, with the information I'm hearing on this panel, the course of action I took would have been a little different. But no, it was like, yeah, that surgery or chemo is the only thing, or they are the only thing available. So I just pray that we'll have more ACB doctors come up in this area and in other areas to help, because we need help in the Black community. I think another thing that's bothering us is religion. You find out that Africans are too religious. When you tell them to go for PSA test, they will pray about it, and they'll say, we are not going. When the doctor says you should be doing this, they pray about it. So how can we break down that mentality? That mindset needs to be removed. Our people come here as professionals. If you look at it, especially West Africans that you are talking about, I know of my country, 98% of people from my country that come here come as professionals. But when they get here, instead of taking advantage of the medical facilities that are here, they keep praying. It doesn't work. So I think panels like this can help let them know that, look, your prayer has a limit. There has to be action on it. Thank you very much.
I just want to weigh in on that prayer bit, if you don't, if just that bit, if you don't mind. Winston, can I go ahead?
Go right ahead, please.
So there is nothing wrong with your culture. There is nothing wrong with what you believe. My job is not to change it. My job is not to, I guess my job is to walk with what you believe. So let me put it to you this way. If you come to me and I say to you, and I've seen it a lot. I mean, I had a case of a pastor, and that's a different story anyway. If you want to pray, by all means, pray. That's fine. But can you also do my bit along with your prayer? I think if you do that, and I've done it a lot of times, and I find that the individual has more confidence in you as a physician, and trust is generated because you don't put down his belief. You don't make him think that, because that's what he believes, right? So, but you've got to walk with his belief. And I've actually been quite successful when people come to me and say, this is what, then I say, yeah, that's fine. Do what you want to do, but let's do this bit as well. And oftentimes, if you give them reason, they do it, and and everybody is happy at the end of the day.
Okay. I got another semi-signal. If any panelist wants to leave now, it's fine. We're going to wrap up with a bit softly. If there's anybody that really is burning, if they have a question in the chat, but it's a question they really want to be answered. They could come forward, put their hands up, and we could try to answer that. I think at most we could give ourselves another 10 minutes or so. That's it.
Yeah. Mr. Klaus,
Yes?
the question about the effect of sugar has not been answered.
Okay. Okay. The panelists, the pressure's on you. I mean, I have my opinions, but I'll wait for the professional
Yeah,
answer.
exactly.
I don't have any comments. Maybe Dr. Goto. I don't have any comments.
Diet
terms of
is a
sugar.
very difficult thing to study because you can't do a randomized control trial where you randomly assign some patients to have a high sugar diet and others to not. And all the data on diet comes from retrospective studies looking back in time and asking people what they ate and this sort of thing. And as you know, things you ate 20 or 30 years ago for decades probably impact your health, but it's hard for people to accurately describe what their diet's been for such a long period of time. So it's really hard to get hard data on how diet directly affects health, but there's certainly some big studies out there, like the Harvard Health Study, that sort of longitudinally tries to capture some of that information that suggests that people that do report having diets that are higher in sugars and simple carbohydrates and things like that are at higher risk for a variety of health problems, including several forms of cancer, and whether that's a direct effect of sugar or it's the link with obesity, where we know that obesity is a risk factor for several cancers. It's hard to parse all that out, but I think generally speaking, avoiding sugar is probably a good thing. And it's true also when you look at prostate cancer, because we're so good at treating prostate cancer, and because as we discussed, we often identify it in older men who have other health problems. It's true that most men with prostate cancer actually die of other unrelated causes, specifically cardiovascular disease or heart disease, and we know that there's definitely a link with sugar and poor diet and obesity and lack of exercise and cardiovascular disease. So it's generally a good recommendation to have a healthy diet and avoid sugar and exercise as much as you can and all that good stuff.
Okay, Bio, thanks for pulling me up there. I think there was a third question too from Mr. Banks that he asked, and wasn't there? Yes, 3 questions.
Was there a question about PSA screening?
Yeah, the third question is about, well, it's not actually a question, but about the interaction between ACB doctors and their clients when they're Africans and versus other doctors, that there is more heart-to-heart talk and more understanding. More information is exchanged. From my own experience, I don't know about other people. And I said that if perhaps if I had gotten more information like I'm getting today, or that I got after my surgery, I would have taken a different approach to my treatment.
Yeah, these are things that part of what the Walnut Foundation and the African Cancer Support Group are doing. Getting professionals and the community to engage in these discussions. And it will help us professionals to develop some way of meeting the needs of our patients, in terms of professionalism, empathy, and just giving time. I had a patient yesterday. He was booked for 30 minutes, but we spent 1 hour. Somebody will say, well, that's your practice. But sometimes as a professional, we have to just be like the patient, because we could also be the patient, turn around. So it's unfortunate you didn't have the type of person that, should have given you some professionalism. But that's what Walnut Foundation are doing. They're creating the opportunity. We are learning from this type of getting together. It will improve our practice. It will improve the outcome we have with our patients. And overall, I think we're going to be better, both patient and doctor.
I just want to add to this, and it's just something that we do. We recognize that if we increase the profile of Black people among health professionals, it will start culturally to kick in, and they'll just, and again, not pointing fingers, the very fact that you're facing a Black person, it would result in more in-depth sort of interaction to the average person who doesn't realize that he has to advocate. And so we have got grants for medical students and people involved with health sciences and towards this end. Yes.
Mr. Class, I'm just going to share a story. I won't take too long.
Yes.
Many years ago, I was practicing in Northern Ontario, and I started the first prostate support group. Now, it was a lot of my time, but at the end, it paid back because part of the members of the support group did actually more work for me in preparing the patients who are coming to surgery. I'll book the patients, and the members of the support group will go to their homes, spend time with them. Those of them who have had the surgery, they will explain every step of the surgery. And, it did a lot of work for me. And that's why, you know how long I've been with your group. This is a good way to go. At the end of the day, the professional, we benefit from your activity. You fellows, you go and educate the patients for us. You prepare them for surgery. You prepare them for radiation therapy. They tell their friends how the injection goes, what to do. This is a good thing. I thought I'll share that with you.
Thanks. Okay, we're winding down now. I wonder, and this is just one last, is there anybody who's got a burning question that they just want to get the answer to?
Am I connected?
Yes, please.
Well, I'm Dr. Levi Omara. I hold a PhD from the University of Calgary. I did postdoctoral training at the University of Calgary here for 2 years. Then I went for further postdoctoral training in the US, became research assistant professor, and I was working on cancer research too, prostate cancer research. I was diagnosed with prostate cancer when I was 50. And here in Calgary, I used to commute, come and visit my family. So my observation is that prostate cancer is caused by red meat and lack of vitamin D, and saying so much for us Black people, working in the offices or in the labs, we are more at risk than those who work in the field. The incidence is the same as at home in Uganda. Educated Ugandans who work in the offices have got the same risk like us who have moved here. But our people who are not educated, who are working on land, exposing themselves to sunlight for about 5-6 hours, they have got lower risk. I give myself, my elder brother got diagnosed with prostate cancer at the age of 80, while I was diagnosed with prostate cancer here at the age of 50. So I'm having more red meat, more working in the labs most of the time, not exposing myself to sunlight. So lack of vitamin D and too much red meat exposes us to prostate cancer. This is my observation, my way. Me, I got treated in the US, and I was having the Blue Cross from the state of Florida. I went to New York. I got the best treatment. I'm cancer-free for 11 years now. So the observation is about the same. But they're saying that black people are more at risk because here we are sitting in offices, not having enough sunlight, and eating red meat, which our people in the rural area in Uganda they don't get. They're all the time working in the sunlight, and they're eating very little meat, maybe red meat is eaten on Christmas Day only. So that's but our educated people in Kampala who are working in offices are with the same risk. They're developing prostate cancer around 50, 60. They're dead.
Very good. Those are very good comments. And
yes,
in my presentation, I think this is an area that is a little bit gray. And I think this is an area that needs some questions to be answered. And that's why we need research people like you to continue to make the observation, bring it forth.
Yeah.
And we should be looking at those factors.
Yeah, was research assistant professor. We read a lot about prostate cancer to put the grant together.
Sure.
And I was staying away from my family. I used just to visit my wife every 3-4 months. So too little sex, maybe I've contributed to it. I don't know.
Those are good questions. We need to form a
Yeah.
group and then look at those questions and see if we can get some answers.
Yeah. So.
You're
Mr.
muted,
Class,
Winston.
you are muted.
Okay.
You are muted, Mr. Class.
Yes. I think I'm going to bring this to a close, and first of all, I know that there are a number of people, a number of you amongst the audience who had questions, and we didn't get around to answering them, and regretfully so. And we bring this to a close because it's just that the time does not permit any further discussion. Members of the panel, I really appreciate the fact that you put aside the time to share your knowledge and experience with us, and we're very grateful for this. And I'm sure we've all benefited from this. What I've been advised to do is to tell you that each of you, once you state your favorite charity, we're going to arrange that a contribution is made to this charity on your behalf to show our appreciation that you showed up today. Thank you very much. I don't know if Bayu has anything to say, but Bayu has anything to say.
It's okay.
Close things up. Yeah.
Okay.
You're muted.
Yeah. Thank you so much, panelists. We really appreciate your presence today. We cannot put value in your presence, so there is no amount we can actually together for you. So thank you so much. As you see, both of us are very young in terms of our we've been operating. I mean, Walnut is a bit older. We are so lucky to be working with Walnut, and we've been together now for a few years. So we just want everybody to know that, you can send your donations to the Ladley Foundation or the Walnut Foundation, whichever one you would like to. And the second chance at Ladley.ca or info@thewalnutfoundation.com or any other form that you like there or on the screen. The last thing I want to tell you is that we are going to be sending out a quick survey immediately after this. We will highly appreciate your response, because that's the only way we, improve on what we are doing. So please look forward to that. And also the presentation today will be posted, and we will let you know when that happens. So thank you so much. There is nothing else for us to say. We just want to say thank you for being here today. Thanks to Dr. Muto, Dr. Goto, and Dr. Abara. We really appreciate your presence. And of course, to my very good friend, Mr. Patrick Tuguda, we appreciate everything that you have said in here today. Thank you, and we look forward to seeing you again sometime next time.
Thank you very much.
You're welcome. Bye-bye.
Thank you. Bye, everyone. Thank you.
Bye, everyone. Bye.
Thanks for having me.
Bye. Thank you.
Bye-bye.
Bye.
Bye.
Mr. Klaus?
Yes, I'm still here.
You hear me?
I can hear you, yes.
Okay, okay.
Is this still recording?
No, I think the recording should be stopped now. Yeah. Yeah, so thank you so much for moderating today. Really